while we're just starting, I want you to put your hands up if you've ever had a course of antibiotics. There's quite a few of you who've got both hands up, which suggests you're on antibiotics right now. Okay, so we've grown accustomed to the ubiquity of antibiotics for treating all sorts of infections and illnesses. It's pretty much a kind of everyday expectation that we can have them available. I'm going to come back to this image in a couple of minutes. But basically, whether you've had antibiotics or not, many of us have been exposed to the bacteria and genes responsible for developing resistance to antibiotics. So we are, many of us in this room, carriers of antimicrobial resistance. It's on our hands, it's in our throats, it's in our guts, it's in our toilets, it's in our schools, bedrooms, and it's in this room today. It's estimated that around 700,000 people die annually because of infections that we used to be able to treat fairly routinely with antibiotics, and the situation is far worse in low-income settings. So in intensive care units and transplant centres and cancer care, we're seeing growing numbers of patients who are also pan-resistant to antibiotics. That is people who are effectively untreatable. So every year around the world, there's around 500,000 new cases of tuberculosis resistant to antibiotics. And it's estimated that by about 2050 or so, annual mortality directly attributable to AMR will rise to around 10 million. Okay, so what can we do? What are we doing? Well, we can reduce prescriptions, we can get patients to take a full course, we can get patients to stop putting antibiotics down the toilet and disposing of them in that way. We can prevent over-the-counter sales, we can limit their use in intensive farming and agriculture, we can use public funds to subsidize pharmaceutical companies not to sell antibiotics as blockbusters, but instead to hold them in reserve for future use. And of course, we can try and produce a whole new generation of antibiotics. Okay, so all of those strategies are really sensible, but the problem with resistance is that it's not some unusual kind of aberration. Resistance is an entirely normal feature of natural evolution. And resistance really occurs very rapidly as well. So we humans pass on our genes generationally. It takes a long time for evolutionary change to occur. But bacteria are able to exchange genes for resistance without even having to reproduce, almost instantaneously. So resistance is inevitable. You might even say that resistance to resistance is kind of futile. Okay, so is there something we're missing? Is it worth thinking about this as a question, possibly even of how we live, and how we lived before antibiotics became available, and what it is that we may have forgotten or lost as antibiotics became ubiquitously available in the last half century. So my background is as a medical sociologist, anthropologist, and the first question that an anthropologist asks is, what is it that makes a particular kind of way of life possible? And that might be people's beliefs and value systems and superstitions, but also where people live and how they live and what they live in. So the arrangement of huts and buildings and villages and camps. Now, as a medical sociologist, I spend a lot of my time in hospitals and clinics where people receive treatment, places like this, because that's where medicine is often done. One of the things that fascinates me is how that these particular kinds of spaces and these buildings reflect different ideas about the body and about health and about the nature especially of infections, and how different they are as well to the kinds of spaces of the past. Okay, so I think there's something extraordinarily haunting and enigmatic or evocative about those pre-antibiotic images of bodies at rest in the kinds of fresh air wards of the 19th century. So the fresh air cure works through things like convalescence, rest, moderate exercise, better nutrition, but also and especially fresh air and sunlight. We know now that the tuberculosis bacterium desiccates when it's exposed to ultraviolet light. Sunlight also boosts the production of vitamin D, it stimulates the immune system. We didn't know back then, but we do know now that bacteria are killed by hydroxyl radicals. So these are short-lived airborne molecules carried on fresh air. They're naturally produced by vegetation and a reaction between water vapor and ozone. So the story that I'm interested in is in how antibiotics have shaped healthcare environments and how the AMR crisis might encourage us to think about these kinds of spaces and speculate on possibly post-antibiotic designs for healthcare environments. And much of this stems from several projects. One is pathways, practices, and architectures containing antimicrobial resistance in the cystic fibrosis clinic. So why cystic fibrosis? Well, the lungs of people with cystic fibrosis are heavily colonized with pathogens that can easily cross-infect between people with cystic fibrosis. So these people spend a lot of their lives on antibiotics, and they also spend a lot of their lives avoiding other people with cystic fibrosis. In effect, if two people with cystic fibrosis share any kind of space or they meet, they can kill each other. So some of you may have seen that recent movie. It's called 5 Feet Apart. It's a kind of a film or a story where a dangerous romance develops between two people with cystic fibrosis. And all of the clinics that we work with have stories of these kinds of tragic romances that develop. And the problem for them is, how do you prevent these people meeting in hospitals and hospital buildings that are usually designed for bringing people together? Hospitals that often have deep density, overcrowded kinds of layouts. And in another project, we've been working with colleagues at the Royal College of Art to develop exhibition materials, exploring these shifts from the pre-antibiotic to a potentially post-antibiotic hospital world. Okay, so let's start by going back to the pre-antibiotic. So this is an architectural drawing of a late 19th century children's ward. It's in Boston, Massachusetts. It's a classic variant on a number of designs for fresh air wards of the period. And this is a medical discourse that's influenced by miasmic theories of contagion. So illness is a product of chemical processes and fermentation and putrefaction. So air must move if it's not to fester. Each bed has a window, its own window, opening onto a surrounding balcony, and beds can be wheeled outside during the daytime. There's also a central chimney that's drawing air in and up and out, so the whole design is about the introduction of fresh air and sunlight. And it's worth remembering actually what kind of body it is that the pavilion is based upon. So from the French, papillon, literally the butterfly tent. As we move into the end of the 19th century into the 20th century, we see a transition from miasmic kinds of designs to germ theory designs. So in the context of germ theory, there's a new emphasis on the problem of touch and the prevention of contact between people and objects and surfaces. So here we start to see the segmentation of hospital space. And you can see here the introduction of cubicles, reducing the risks of contact and contamination. Okay, so we've discovered bugs, but that emphasis on light and air and open space remains. So a few weeks ago, I visited the new Wellcome Collection exhibition at the Science Museum in London, where you'll find this wonderful 1932 King's Fund miniature model of a hospital design, so state-of-the-art for the time. And here you'll see the arrangement of wards and beds. It's quite spacious by modern standards. And there's also this kind of fully glazed, cylindrically shaped kind of series of day rooms surrounded by balconies for convalescents, possibly after surgery and so on. These are the operating theatres with these fantastic designs for a kind of fully glazed bay on the outside of the building to kind of expose the operating theatre to natural daylight, sunlight, to the maximum possible. And you almost get the impression that the architects, if they could, they would have taken the operating theatre out of the hospital entirely and had it outside of the building rather than inside the building. And at the same exhibition, you can see this, which is it's a model made by a very proud patient of the hut that they were housed in at Papworth Fresh Air Hospital just outside Cambridge, again from the 1930s. Two of the most famous examples of this emphasis on air and light are the clean modernist designs of Jan Duca's Zone Astral, just in the Netherlands, and Paomo by Alvar Aalto, just outside Turku in Finland. Both stunning examples of 1920s tuberculosis sanatoria. Okay, so what happens when antibiotics come on the scene in the latter half of the 20th century? Okay, so I want you to think about this space. Again, hands up if anybody's ever spent any time there. Yes, that's right. Yeah. Some people got their both hands up. Yeah. York is actually a very special hospital. It's a very special space. It was celebrated at the time it was built for being one of the most cost-efficient hospitals ever constructed in the United Kingdom, and pretty much holds that record, I think, since. So it's got a really tight geometry. It's got very low ceilings. It's got very densely arranged ward bays. There's an attempt to circulate light and air with this kind of wraparound system of glazing, and also the positioning of internal garden courtyards that many of you will be familiar with. But basically, York is an incredibly dense and packed hospital environment. So, like lots of similar hospitals, it has a main single entrance into a public atrium that's crowded with waiting areas and shops and cafes. There's a pharmacy, there's a welcome information desk, and so on and so on. Now, the historian, Robert Budd, and other historians suggest that antibiotics have concentrated healthcare delivery within ever more efficiently compact architectural designs. So arguably, what makes York possible, in fact, is the availability of antibiotics. So infections become a matter for pharmacology rather than design. So antibiotics rather than sunlight and space and fresh air. Okay, so what do we do if antibiotics are failing and if the hospitals that we built around antibiotics are failing too? Okay, so if you followed the TV series The Bridge, hands up, anybody who's seen The Bridge? We're doing lots of hands. Yes, good, yes. Again, some people have got both hands up. It's very good. So The Bridge, you will have seen this in the opening credits. So this is an infectious disease hospital in Malmö in Sweden. It was one of the first architectural designs specifically for the post-antibiotic era. That was the architectural brief. So each of its individual patient rooms are accessible directly from the outside, from these kind of wraparound balconies. So there's no single entrance into the hospital. Instead, there's lots of different individual entrances, so people can come in and out of this environment without necessarily mixing. Each of those walkways is semi-open to the fresh air, protected by these long glazed panels. So it's quite startling, in fact, how the layout of this building is so reminiscent of that kind of pavilion design that I showed you earlier on. Most of the rooms have these really expensive air pressure systems, so you can increase the pressure within the room to protect patients from pathogens outside, or you can reverse that and you can decrease the pressure to prevent infections coming in. So controlling air pressure in this kind of way relies upon a really sealed kind of environment, and that those airtight doors have really got to be locked and working. But when I was there last, a couple of months ago, the staff were telling me how patients like to prop the door open to the outside, completely defeating this multi-million, quadruple expensive air management system, because they want the fresh air, but they also want to hear the city. They want to hear voices and they want to hear traffic. Now, there's lots of other examples of hospitals built along those kinds of designs, sometimes actually in resource-challenged kinds of areas, in quite simple kinds of ways. Post-antibiotic design could also be about materials. So we're starting to see an interest in rewilding hospital environments using biofilms, so surfaces where harmless bacteria can grow to outcompete resistant pathogens, or bioreceptive designs and the use of things like concrete and stone and untreated woods and cork and grasses. Hospital designs in the developing world have often actually drawn on these kinds of principles, bringing the external environment necessarily into the internal clinical space. In some of this, I think there's also an interesting critique of a 20th century infatuation with hygienic sterility and the idea that all bugs are bad when we know that's no longer the case. So I'm going to stop here. I don't want to romanticize the past. This isn't about a return to some kind of bucolic world of sunlight and sunshine and fresh air and ecological harmony. People routinely died in their droves in the fresh air wards of the 19th century, and antibiotics have made lots of lives, indeed in this room, possible that would have otherwise been snuffed out. But they've also underpinned ways of living and even building that are now called into question. So a recent article in The New Scientist speculates on a future where we may well see architects and doctors and building managers, they don't mention patients, but working together to take account of our microbial companions. And we might, who knows? So this is a bit of a provocation. I'd like to acknowledge my colleagues here, and thank you very much.